Hi, everyone. I'm Giza Lopez. I am the Executive Director of the New York State Youth Justice Institute. Let me start by welcoming each of you to today's webinar and this Lunch and Learn series. We appreciate that you took time off your lunch break to learn more about youth justice research. Feel free to introduce yourself in the chat, and if you feel like it, go ahead and share with us what your favorite Halloween costume was when growing up. Mine was, let me think, olive oil. I want to also express my thanks to our partners in New York State, the University at Albany, the Division of Criminal Justice Services, the Office of Children and Family Services, as well as the New York State Juvenile Justice Advisory Group. Without their support, we wouldn't be here today. It is my pleasure to be the very first here today to welcome today's speaker, Dr. Meza. Dr. Jocelyn Meza, thank you so much for joining us. We can't wait to see what you have in stock for your presentation today. I'm going to pass the baton on to Alicia May, who is our research and evaluation specialist here at the YJI, and she will facilitate this conversation. Alicia, the virtual floor is yours. Thanks, everyone.
Thank you, Giza. Hello, everyone, and welcome to the Youth Justice Institute's Lunch and Learn webinar series. As Giza said, my name is Alicia May, and I am the Research and Evaluation Specialist at the YJI. Today, we're bringing you some cutting-edge research on juvenile justice issues in what we hope is a thought-provoking and engaging format. Today's topic is suicide prevention supports for systems-involved youth and their families, presented by Dr. Jocelyn Meza. Dr. Meza is the principal investigator and the director of the Health, Equity, and Access Research and Treatment Lab, or the HEART Lab. She is also a licensed clinical psychologist and an assistant professor in the psychiatry department at UCLA, and her research interests include studying socio-ecological risk and protective factors for suicide and self-harming behaviors among Black and Latinx adolescents and young adults. She aims to integrate psychological, cognitive, and sociocultural influences to predict suicide and self-harm behaviors, and importantly, to identify therapeutic targets for culturally responsive interventions for ethno-racially minoritized youth. In addition, Dr. Meza is expanding her research to developing and testing digital tools for suicide prevention for college students. Her presentation today is titled Equitable Solutions for Suicide Prevention, focusing on systems-involved youth and families. So without further ado, Dr. Meza, the floor is yours.
Great, thank you for that warm welcome and the introduction. I loved reading the Halloween costumes. I think my favorite one was somebody that dressed up as a television set. I'm like imagining how your outfit looked for Halloween. So thank you for sharing. Alrighty, so let's jump into the conversation and dialogue that Alicia is going to be moderating. Good afternoon, everyone. For me, it's good morning. I'm on the West Coast. I'm excited to share a little bit of the work that I've been doing with families, and excited to learn more about how we can, better integrate some of these things into the different systems that our youth are embedded in. These are just some of my current funding mechanisms that support the research that I do with youth involved in child welfare and the juvenile legal system. I will be sharing my slides. So this is my obligatory disclaimer that is required when I share my slides. You are all free to use the slides for your own learning purposes. And I also like to start with a trigger warning. We are going to be talking about very sensitive topics, like the topics of self-harm and suicide. So if you need to practice self-care and step out, please feel free to do so. I am also including the national hotline number 988, which started about a year ago. And if you want some more resources for suicide, please feel free to reach out to me or to anybody from the Youth Justice Institute. I will leave my email at the end. Okay, so to give you a roadmap of what we will be discussing today, I'm going to be talking about some important language when talking about suicide that I think is very important, not just for researchers, but for clinicians. to think about destigmatizing language when discussing suicide. I'm going to spend a little bit of time talking about suicide within different systems that impact youth. And then I'm going to spend most of my time talking about a new intervention that we developed for children that are placed out of home to improve family communication and their reintegration back into the home setting. And then if we have time, I'm going to wrap up with some possible equitable solutions for suicide for youth that are impacted by the juvenile legal system. So a little bit of everything here, all of it around equitable suicide prevention for youth impacted by different systems. So let's start with language for suicide. I always get asked, what's the most appropriate language, especially when it comes from parents. So one common term that I've heard repeatedly that I'm hoping we can move away from is the term committed or completed suicide. So what's wrong with this statement or this language? So this language really criminalizes the mental health act, right, of dying by suicide. So the recommendation that we say is that instead of saying committed suicide, which is stigmatizing and has some criminal underpinnings, is someone died by suicide. The same thing that I've heard from a lot of MDs in their medical chart notes is when they say they've had a successful attempt. That is not something that we want to attribute success to. So instead of using successful or unsuccessful attempt, we just say they had a suicide attempt or they had a suicide death. One other term that I think primarily comes from the youth themselves that experience this is the term suicidal. So what's wrong with using the term I am suicidal, I'm a suicide ideator or a suicide attempter? This really makes it seem like it's a personality trait, something that is fixed, something that won't change. And sometimes with youth, it becomes part of their identity if they say they're suicidal. With one of my hardest cases that I see in my clinic, one of the main things that I did to improve their outlook on life and their adherence to treatment is I had them change their language that they use to address themselves. So with time, they moved away from saying, oh, Dr. Meza, I'm suicidal, to I am having thoughts of suicide. Or I've had a suicide attempt. I engaged in suicidal behavior. This makes it different, and it moves away from it being a fixed state. And then just to wrap some things up, the term suicidal gesture, which we used a lot around 2010 when this term was developed, it really became very stigmatizing especially for adolescents, saying that it was a gesture to get attention. So we really try to move away from these types of terms and move into describing the behavior. Again, these slides will be available to you. There are other terms, but I think these are the most common that come up in my practice that I really hope everyone can start changing the way that we use these terms. So suicide in the last 20 years has not improved, especially for youth that are in their adolescent years. Currently, the most recent data point to suicide being either the second or third leading cause of death for children, adolescents, and young adults. This is problematic because we have been developing and testing treatment interventions for 20 years. Why are we not seeing an improvement in these numbers? Even more alarming, at least for me in a current area that I'm focusing on, suicide for the first time ever has emerged as the top 10 causes of death for children ages 5 to 9. So the reason why I like to highlight the top 10 leading causes of death in the United States across age groups, because I feel like it really does show or depict in a visual way the public health crisis that we all together collectively need to address. Now, I do have a quick polling question because this doesn't give us a sense of what are the numbers like. So The question on the screen that should have popped up is, what percent of teens in high school seriously consider suicide in a given year? And if people can submit their vote or what they think are the rates are on those rates. And this is in a given year, not lifetime. Whenever we ask or we poll high school students across the US, if they've had seriously considered suicide, how many do you think said yes, they have seriously considered suicide in the last 12 months? We'll give it a few seconds. Looks like most people have submitted their vote. We're at 104. All right, I'll wait 10 more seconds so that everyone can participate. All right, it looks like we're at 115, so 83 participation rate. All righty, so let's see what most people said. Alicia, can you give me a thumbs up? Can you see the actual breakdown? Okay, perfect. So it looks like most of you said 30%. Oh no, actually 22%. Most people said that 22% of high school students considered seriously suicide in the last 12 months. And that's absolutely right. These surveillance points are from the Youth Risk Behavior Survey, which is a survey that's done nationally for high school students across the US. And 22% have seriously considered suicide. For those of you that said 30, you're not far off. 30% of high school girls have actually reported that they seriously considered suicide. So that point was for girls across high schools. Out of those 22% that have seriously considered suicide, not all of them have reported a suicide attempt. 10%, which is about a 2% increase from the previous years, 10% have reported that they had a suicide attempt. And out of those 10%, 3 reported that they had a pretty severe injury due to their attempt, that they needed some sort of medical treatment. So I think these rates, again, really paint a picture of the current state or the current mental health crisis that is impacting high school students. But one thing that we have to think about is that the data that I just shared 2 seconds ago, these are from students that are completing the survey. These are students that are enrolled in a high school, and these are the kids that actually show up to high school to be able to complete this survey. Let's think about, what are the kids that are not showing up to school, are maybe not enrolled, are having a hard time re-enrolling into high school? Who are those kids that are not represented with these data? These kids are the kids that are impacted by different systems and are not, their data is not accurately represented. Some of those groups that are not accurately represented, specifically in the Youth Risk Behavior Survey, these are kids that are impacted by child welfare, especially if there's significant number of care places, and then the juvenile legal system. One of the main issues that the youth that I work with, I am a psychologist in the juvenile mental health court in Los Angeles. One of the main issues that the youth report after being detained or incarcerated is their reintegration back into school, right? So especially the re-enrollment. So how can we think about suicide prevention for these youth that their surveillance data is not accurately collected in these large systems? So this goes to my polling question number 2. So we just talked about how suicide impacts kids in the general population, kids that show up to high school. I want us to think about kids in juvenile detention. So the question is, suicide is blank leading cause of death for youth in juvenile detention. And the answer options are 1st, 4th, 5th, or the 10th leading cause of death. And we'll wait a few seconds for people to submit their vote. All right, it looks like 1st and 4th place are tied. We'll just give it a few more seconds since I see a lot of votes coming in. All righty. So we have over 80 participation, though. We will share the results. All right, so most of you said that suicide is the first leading cause of death for youth and juvenile detention. We had a few of you that voted that it was fourth. For those of you that said that it's the first leading cause of death, you are absolutely right. Suicide is currently and continues to be the leading cause of death for youth impacted by the juvenile legal system. In a little bit, we're going to talk about how there's different entry points into the juvenile legal system. And the further in that you're impacted by the legal system, the higher the risk for suicide and for reentry. It looks like reentry and self-harm kind of go in tandem and together within the system. So we're going to be talking a little bit more about that down the road in a few slides. So a lot of the youth that we've been talking about are impacted by both systems. Sometimes we refer to children that are involved in both child welfare and juvenile legal system as dually involved youth or crossover youth. And why is this an important piece? This is an important piece because both of these systems interact to increase risk for suicide and risk for further being diverted into appropriate care. So current data shows that youth that are impacted by child welfare, about 50%, so nearly half or half of them are referred to juvenile court for delinquency. And youth with dual jurisdiction, so these are the kids that are impacted by both, make up 1% of informal diversion cases. We want that number to be substantially higher. We want these kids to be diverted into care and into appropriate services. So what can we do to make sure that kids are diverted into the right appropriate care early on, so that they have an equal chance of having a successful life, and reintegrating back into school? We're going to be talking about that in a little bit. So in a recent study done by one of my colleagues where they looked at children that were placed out of home, so in out of home care, they found that those kids that were in out of home placement or in care had suicide attempts 3 times more likely compared to kids that were not placed out of home. So how can we think about how placement impacts suicide, which is something that we have been doing in my lab. We've been looking into what type of care, what type of placements are linked with suicide or suicide risk, and how can we address that in the treatments that we're providing. Data, like I said, or surveillance data for youth in the legal system, it's hard to find since surveillance data, like I said, doesn't really capture some of these higher risk youth. But from some of the most recent data from the national surveys of youth that are in detention, rates point to 70% of youth that have been detained. 70% report a history of suicidal behavior, this includes non-suicidal self-injury, so cutting or burning of the skin, or any previous attempt. Now, the number that I'm reporting here, 70%, some data is starting to look at what point does risk for suicide emerge? Is it prior to involvement or after involvement? And what we're finding is that there's different groups. Some kids enter the juvenile legal system with already histories of attempts and with risk for suicide. And then there's this unique group that comes in with no previous histories of self-harm. And then after they reintegrate back into society or their reentry point, they are reporting risk. So there's different groups of what we call high risk for suicide. 46% of youth that have been detained report a previous suicide attempt, and 31 report suicide ideation. One very key point that I kind of want to highlight here, and I want people to think about, perhaps they can share in the chat. In the general population, we see that suicide ideation is higher than suicide attempts. Here we see the reverse. We see that rates of suicide attempt are actually higher than suicide ideation. And I want to hear what people have to, why they think we see the reverse effect or the reverse, numbers for kids that are in detention. So what may be driving this difference here? Some of the risk factors that are impacting these really high rates of both risk and of suicide attempts is childhood trauma. So most of the studies that have looked at what predicted their suicide attempts have looked into childhood trauma. Rates point to 90% of youth that are impacted by the juvenile legal system report a previous trauma history, with rates being a bit higher for sexual gender minority youth that are in the system. For girls in particular, we have found in our data that girls that are impacted by commercial sexual exploitation, the risk for suicide is 3 to 4 times higher. And for some specific risk factors for suicide that have emerged more recently, homelessness and running away from home have both been shown to increase risk of later attempts. And if we think about it, both homelessness and running away from home, what may be going on in that youth's life that may be leading to that? Is there something going on in the family structure? Is there something going on with their caregivers that may be impacting their risk? So the point that I want to make here is that homelessness in itself is not the risk, is the reason why that's happening. Are the kids not having ample support in their family or in their neighborhood? Do they not have an adult that's present in their life to keep them safe? Other risk factors that have come up a lot, especially in juvenile legal system involved youth, is externalizing behaviors. Not so much internalizing, which in the last 30 years, depression and anxiety have emerged as what we call the leading contenders in predicting suicide. For youth in the system, it's actually the reverse. It's not internalizing behaviors, it's externalizing behaviors like attention deficit hyperactivity disorder, conduct problems, and ODD that seem to have a stronger effect in predicting their suicidality or their suicide risk. In a recent study that we did with girls, 360 girls in Los Angeles that had previous commercial sexual exploitation, we found that the combination of having one parent that was incarcerated and having more than 6 out-of-home placements, that combination was the worst combination that these girls had in predicting their suicide attempts. So it's not just risk factors at the individual level, like symptoms of depression, symptoms of anxiety, attention deficit hyperactivity disorders. It's things in the broader context. In this case, things that happen in the family context and in the broader system context, which is what my research tries to do. Is we really try to focus on the social ecology and where the youth are embedded in, so that we can address those contextual factors in the treatment that we're providing. So I really don't want to end the conversation from a deficit perspective. There's also a lot of resilience and a lot of protective factors in the work that we've done with these families. In a very recently published study, we looked at 400 children in the East Coast, in Rhode Island. We looked at 400 youth that had their very first involvement in the court. And what we did is we looked at their histories of cutting behavior, and we tried to understand what was protective for those kids that didn't engage in that behavior, given that they were already conferring risk by being part of the juvenile court. And what we found was those youth that had or reported high family support and good communication with their caregiver, those youth were less likely to engage in self-cutting behavior. So there was something about the family system that buffered or really led to a protective effect in their self-harm history. So with this context in mind on how important the family system is, we developed an intervention to improve family communication. So this is the Family Telehealth Project. We did a cultural adaptation and where we linguistically adapted the intervention into Spanish. And what we did is we developed a brief intervention that focused on skills for the caregiver and for the youth that was placed out of home. I do want to note that this intervention was specifically designed for families that had a youth that was placed out of home. So when they're placed out of home, we can imagine how communication gets really difficult, how conflict may be something that's happening in the family system. So we address this situation or this issue by specifically focusing on families that had an out-of-home placement. We focused, like I said, on really improving family relationships by giving them the skills for communication. And we also taught them skills on how to effectively manage strong feelings and communicate effectively. All sessions took place over Zoom. So when we adapted this intervention, it was in the middle of the pandemic. So this was around 2021, 2022. So they all were remote, and families, this really allowed families to participate wherever they were. These were from families that were placed in San Francisco. This was back in my time when I was still training at UCSF. And for some of these families, their kids were placed really far away from the home. So this really facilitated their participation into the intervention that we developed. To give you a sense of what we taught in each session, so we had 5 sessions. Actually, we had 6. Session 0 focused on motivational interviewing. So the whole session focused on getting the parents and the teens to a point closer into engaging into treatment. A lot of these families were treatment naive, meaning that they had never been in treatment. So they weren't really sure if we were a trusted source. They thought that we were part of the court. A lot of the work that we had to do is to really build that trust with those families. So session 0, where we did motivational interviewing, was so important for building that trust with those families. We told them that their participation in this was not going to affect their court case or their child's placement. And that really helped with parents trusting us as a provider. Then in session 1, we did a lot of psychoeducation on trauma and how trauma manifests in the body. We also talked about healthy relationships and how those are really important in the relationship that they had with their kids. Session 2, we focused on managing feelings or really strong feelings and effective communication style. Session 3, we focused a lot on typical and atypical adolescent development. A lot of the things that parents were really frustrated about were just typical adolescent behaviors. And us talking about the differences of when something becomes atypical, they reported that as being really helpful because they had never had an open discussion into that. We also talked about how they can stay involved and monitor their children in an effective way, and also talked about risk planning. So by risk planning, I am talking about both suicide risk, substance use risk, and sexual risky behaviors. Session 4, we talked about validation, which is a key ingredient of dialectical behavior therapy, which is the most robust intervention for suicide that we currently have. And we also focused on values, which is another core ingredient of acceptance and commitment therapy. So we integrated those core ingredients into session 4. And then at 3 months, we did what we call a booster. We checked in with the families. We asked them how they were doing with the skills that we had taught them, and if they wanted, a booster session to practice the skills more. One of the things that made this intervention very effective and useful for the families is we created animations to depict some of the components that we wanted to teach. We had videos, in our case, for the Spanish version, we had a lot of telenovelas clips to show effective versus ineffective communication, emotion regulation, so that made it more engaging. We also had the parents and kids role play in sessions together so that the skills could be, reinforced. We also had games. We had Jeopardy, Trauma Jeopardy, where we had the parent and kids learn about different trauma. And then for homework, we always gave them interactive worksheets that they would bring back. We did an open trial with 11 families. 100% of the families that participated were Latine. Most of them that participated were on public assistance. And most of the teens, we only got 4 teens out of the 11 families to participate. Most teens reported that they were sexual gender minority. The ratings were overwhelmingly very positive. We asked at the end of every session how helpful the content was, how interested it was, and how comfortable the participants were with video technology. And as you can see here, the ratings were pretty high. Given that all of the clinicians were Spanish speaking and also Latino and Latina, I was one of the clinicians. We had 100% of the participants like their clinician. And one important point that I want to point to is that 72% of the participants engaged in the therapy with a phone. We were not expecting that. We just assumed that most families were going to join with a family computer, but that wasn't the case. And in some of the sessions, both caregivers and teens reported that they had connection issues, like the internet or their phone dying because they had older phones. I won't go into too much depth into this, but we saw pretty good outcomes in terms of improvement in emotion regulation and improvement in positive communication at the end of the 4 sessions. And then we saw a dip in when we did a 3-month follow-up. And I can talk a little bit more about that in a bit. So I think the take-home message that I want to share from the family telehealth intervention is that skills can be learned and used in real time with the families that we're working with. It can be delivered adjacent to other services or while families are on wait list. For the families that we served, like I said, for a lot of them, this was their first time getting care. And for a lot of them, they had a hard time finding a provider that was Spanish speaking or a provider that, worked with out-of-home families. We used a lot of community feedback to improve the cultural relevancy of the intervention. And then we also gave the families additional referrals for if they had immediate safety concerns. So one of the teens, while they were participating in our trial, had pretty high suicide risk that they had to be put into a higher level of care. And that was part of the intervention, right? To put them into the right level of care and to receive the appropriate referrals. This is just for your own learning. If you are thinking about using telehealth in your setting where you're in, we developed a set of 11 tips on how we think you can engage families that have a youth that's placed out of home. This is my summary sheet, and it will be shared with everyone on how you can better integrate and engage families into treatment. Alicia, how am I on time? We're good? Okay. So in the last 5 minutes, I do want to wrap up on how can we improve suicide prevention for youth that are impacted by the juvenile legal system? The most upstream thing that we can do is abolish the juvenile legal system. While there's still a lot of activists working on this, there are some things that I think we can still do at the individual level as clinicians or as partners with the court. There's different intercepts that are associated with the sequential intercept model. So if you look at intercept 0, that's at the community level. All of these intercepts allow for diversion into appropriate care. And a few slides back, I talked about how further in or intercept 4 and 5 are associated with the highest risk of suicide. So what we want to do is we want to prevent further penetration into the sequential intercept model. So how do we do that? I'm going to skip to this last slide that talks about the different solutions that I proposed. These will be available to you, and they're all summarized in this last slide where I will wrap up. So at Intercept Zero, one of the main issues is that there is a huge school to prison pipeline that disproportionately impacts Black and Brown youth. What can we do to disrupt this pipeline so that we're getting the kids that need care into the right care and not into the legal system? One possibility that we can implement is to use anti-racist school organizational and policy changes. An example of that, and something that we've been working really hard on in some of our research, is how can we screen for race-related stress in school settings, and how can we address it in the school setting? We know that the school setting is an excellent place for us to be able to provide resources for families, for community care. So how do we do that while addressing some systemic issues that impact the youth? At Intercept 1, which is law enforcement or crisis intervention, a lot of criminalization of suicide is impacting the care or the lack thereof that youth are receiving. One recent implementation was the implementation of 988, and a lot of people were concerned that this would lead to more legal involvement for mental health issues, and the data are pointing to only 2% of 988 calls are actually ending in legal involvement or law enforcement being sent to the home. And we do need more anti-racist police responses. How can we further decriminalize crisis response? How can we make sure that the crisis responders are actually trained in anti-bias and how to de-escalate situations? Intercept number 2, court settings, which is mostly where I'm embedded in. Court settings are not the best place to screen for suicide risk. It's chaotic. Youth are really stressed because they fear that their responses to the suicide screening is going to somehow impact court decisions. There aren't any, safe places, not safe places, but any discrete places or places where they feel comfortable, where they can do their risk assessment. A lot of times they're doing it in the hallway. That's not an appropriate place for kids to be doing a risk assessment. So how can we think about the actual physical setting being more appropriate for screening? Intercept 3, youth confinement or detention. A lot of the risk assessment that's done in detention settings is using most often than not the MACI. So how can we integrate other risk assessments that can better capture risk? And then one of the possibilities that we talked about is implement Safety A. So Safety A is a family intervention that we were thinking of using during family visitation. So how can we use family visitation as a window of opportunity to improve family communication? And then Intercept 4, engaging parents in the reentry process. How can we coordinate care better, especially with probation? How can probation be trained to be gatekeepers for suicide risk assessment? And I'll wrap up there because I know I'm like super over time. But at this point, Alicia, I'll let you take it away with some comments or questions that you may have.
Great. Thank you so much, Dr. Meza. This has been an awesome start to the conversation, and we have some audience Q&A in, and we have some questions prepared. So if people in the audience want to ask more questions, please feel free to do so. We will not get to all of them, but we'll get to what we can. The first question that we wanted to ask you today is about common myths about suicide. Are there some common myths that you would like to bust for our audience today?
Yes, I would say the leading myth is that somehow asking youth about suicide is going to increase the likelihood that they are going to think about suicide. And I've heard this to be true for like confinement, and I say no. the literature actually points to the opposite. Asking or assessing for suicide risk decreases suicidality or suicide risk. It has like a therapeutic effect when we screen or ask for suicide.
Very interesting. And when we're talking about these treatments and talking about preventing suicide, what are some things that are found to work? So we're talking a lot about the risks, we're talking a lot about what the system can do. Are there things that can work? And tying in with that, are there interventions that can be scaled up? The study that you presented was a pilot, and I guess the curiosity is what more can be done, what can be scaled?
Yeah, that's an excellent question. So there was a review of the 18 trials that have been tested to date with adolescents for suicide. And what they found was that only half of them worked. Out of the 18, only 9 had a positive effect in reducing suicide risk. And what I did is I looked into those 9 trials to see what they had in common. And they had 4 things that they had in common. The interventions that were successful, they all had a safety plan as part of the intervention. So safety planning is key, and a scalable intervention that we can use that only takes 20 minutes to do in community settings. 2, they also had lethal means restriction counseling. What that means is that the parents or the caregivers were giving counseling on how they can remove potentially lethal arms or means from the home. Number 3, the interventions that were effective had a parent component, meaning that they were teaching the parents the skills that they were teaching the kids. It's really hard for us to teach adolescents emotion regulation skills when we're not teaching the parent the same skills. We have to think about the context that the youth are embedded in. So we want to make sure that we're also helping the parents and giving the parent the skills, or else it will be really hard for us to see a treatment effect. And then number 4 was skills for the youth themselves. So number 3 was skills for the parents, and number 4 was skills for the teens. Skills that could be used in everyday settings, skills that they found, useful. So if you were to ask me what intervention would I put my money on that we can scale up, would be an intervention that focuses on safety planning, lethal means restriction, and skills for both parent and the youth. And there currently is one intervention called Safety A that includes all of those components in a very nice packaged intervention.
Yeah, and it sounded like Safety A was something that could happen in person. And one of the things that's really fascinating about the work that you shared with us today is this telehealth element. And so with what you presented today, we know that the Family Telehealth Project was studied for Latinx populations, but this seems like something that could be really helpful and engaging for other families. So we're curious, have there been other studies, or are there plans for studies incorporating this type of programming for other racial or ethnic groups?
Yes, absolutely. So the Family Telehealth Project was actually first developed for a wider audience by Marina Touloucham from, at that time she was at Rhode Island, right now she's at University of California of San Francisco. But the Family Telehealth Project was for youth that were in child welfare or juvenile legal system and that had substance use risk. So it wasn't intended to be a suicide prevention intervention. It was a substance use intervention for youth that were impacted by different systems. And like I said, it wasn't just for Latinx youth. It was, broadly for eligible participants. What we did in the last 2 years is we linguistically adapted it, because a lot of the families that we were seeing that had out-of-home placements were predominantly Latino and Spanish speaking. So we wanted to address that access issue.
Yeah, access is so critically important. And with that, we wanted to know, thinking intersectionally, you had one slide where you talked about the different types of identities, and we know that this is a serious issue, that suicide is a serious issue within the LGBTQ plus community. So we're curious if there is a role of competency for clinicians in being aware of and responsive to these sexual and gender minority communities.
Yeah, I love that you asked that, because I think now that we have open trial data, we're noticing that that was a huge oversight, something that wasn't addressed early on. So what we did is we trained clinicians that were already licensed. So you would think, or you would hope, that if they're licensed, that they're adequately trained to address bias or to address specifically sexual gender minority issues, which we know is not the case, right? Even if you are licensed, you still have a lot of blind spots, and you don't receive this training as part of your licensure. So I think one of the things that we want to do as we move forward with a larger trial is that we do want to provide more competency training for LGBTQ issues that come up. And they did come up, Alicia, actually, when we were talking about conflict. A lot of the youth would share with us when we were doing the individual session, like, can you not tell my parent that I go by they? Can you just refer to me as, you know, a different pronoun when we're talking with my parent, because they just wouldn't understand. They're old-fashioned Latino parents. Can you not? So one of the things that I hope to do is to borrow some of the work from Jovanska Duarte Velez, and she has the only randomized controlled trial that addresses adolescent identity issues with Latino parents and their youth. So please read her work. She just published this trial this year. So I'll put it in the chat so that people can read that trial that I'm talking about. But she has a specific whole session dedicated to talking about identity issues with Latino parents and their youth.
That's awesome. Thank you for the resources. It's always good to hear other work that's being done on these topics. We have an audience question that's a clarifying thing. When we're talking about youth, are you talking primarily about 18 and under? And if so, are there different strategies that are more successful when talking about children versus teens versus young adults, knowing that suicide was that top 3 category, top 2 or top 3 in mortality for these populations? Are there different approaches?
Yes, there are different approaches. So the term youth includes youth ages 15 to 24, so it's adolescent and young adults. It doesn't include children. The issue with suicide treatments is that for children, there hasn't really been trials. We used to think that suicide didn't impact younger children, and now we are seeing that it is impacting younger children. So one of the current things that is being developed right now is how can we adapt the current interventions that we have for adolescents for younger children. So one of the things that we will likely use is the parent component. The parent component will be even more important for children when we're comparing them to adolescents. So we will probably focus more on the parenting strategies and the parent efficacy and dealing with or addressing suicide risk in their children. For young adults, we have done work with college settings, and we're finding that they don't have the protective buffer of the parents at home. So a lot of the things that we do is we help them develop help-seeking skills. So in our interventions, what we do is we help them with motivational interviewing on how they can seek care, because now they don't have their parents that make their appointments for them. They don't have their parents that take them to their appointment. So we increase their self-efficacy to seek out treatment.
Yeah. That point of like the parents not being there relates, I guess, kind of to this other question from an audience member asking you to highlight the key differences between youth and adult suicide risk and lethality assessments. One of those 4 things that you mentioned was helping parents remove lethal means. And when the person is a young adult and they don't have the parent there to then remove that, I think that this person is trying to ask about how do you assess that risk and lethality issues for people who are no longer under the care of their parents?
Yeah, well, that's a very good question, and I think that's why it's more challenging with adults. There is a tool called the Decision Aid tool, And if you look up Lock to Live, it's a brief online tool that helps adults or parents that have a youth that has risk for suicide decide how they can keep certain potentially lethal means safe. And it gives them a printout of local, for example, local gun storage that they can go um, to keep their environment safe. But you're absolutely right. When we're working with adolescents, we target the parent and we ask the parent what are some of the, the things that they've used in the past to self-harm. A lot of the times it's sharp objects. So we talk to the parents about how they can remove knives from the kitchen and how they can keep things locked. And we say it's not something that you're going to do forever. It's something that you have to do right now while your kid is really, really struggling. So I hope that addresses their point. And I'll also put in the chat the link to that decision aid tool that has been tested and developed to help people. And you can use it as a provider. I use it as a provider in some of my sessions. I just go to that link and I say, let's go over some potential solutions that you can implement in your home to keep your child safe.
Yeah, there's a lot of question earlier in the chat asking like, what are some of these resources? Like, what are some of the tools? Are they available? So I'm so glad that and thank you to Patricia for sharing the link to Lock to Live. We have another question that's going back earlier into your presentation about risk factors. Can you say more about how this behavioral health and conditions like ADHD, conduct problems, oppositional defiant disorder are risk factors for suicide among justice legal system involved youth, and how prevalent these conditions are among the youth in the system?
Yeah, I'll start with the first point of how prevalent is it. In most studies, it's about 70 to 80% of youth that are impacted by the juvenile legal system have a diagnosis of either ADHD, conduct disorder, or oppositional defiant disorder. So it's more prevalent than depression or anxiety for sure in the settings that I've been in and in the research. The problem with this, Alicia, is that it's oftentimes the wrong diagnosis. And we know that Black and brown kids tend to get overdiagnosed with these behavioral issues that are not accurately capturing the trauma that's underlying that. So it seems to be like a catch-all diagnosis that kids are given. And what happens and what's the problem with that? So the problem when you label a kid with ADHD or conduct disorder, whenever someone sees their chart, they're already biased because they're like, oh, we already know what this kid is going to look like. And I've seen it happen almost every day, Alicia, where they're like, oh, we already know this is going to be a defiant kid, huh? Or this is going to be a hard kid to work with. So a lot of the times I have to do some psychoeducation on how that may not be the right diagnosis and how we need to rule out PTSD or other trauma that may be underlying it. But the bigger issue is that they don't get into the right care if they're diagnosed with ADHD, right? They're sometimes put on medication or sometimes not put into the right type of therapy that addresses, like I said, this underlying trauma that is manifesting in a different way for these kids. So I think to me, that's like my biggest challenge to date is this diagnosis.
Yeah, that's really sad and like disheartening, but also like the reason why it's so important to have these conversations to introduce people to these issues. And with that, there's a question from the audience about practice implications of your research for those working within detention and placement. And so for practitioners who are in the field, who are currently working with youth, what are some of the things that are practice that they can do, they can implement?
Well, one of them is think about how you can integrate suicide risk assessment into the work that you're doing. One of the things that I think would be really helpful is probation officers. They oftentimes develop a really close relationship with youth and are part of their care. So how can we work with probation officers into giving them the efficacy that they need to address suicide while the kids are back in the community? And I think that across any placement, right? Across detention, across reentry, court settings. I think assessing for suicide at all points is so important. And I already mentioned previously, asking about suicide does not increase risk for suicide. So we need to get into the habit of doing it in a way that is going to help kids connect into care. Another thing that you can do from a practice point is integrate the family as much as you can. If kids are in detention, how can we better use family visitation as a window of clinical opportunity to engage the families? A lot of the families that have a kid that's in placement have a lot of fears of how this may impact their immigration status. So sometimes they stay away because they don't know how they can be involved. So as much as you can build that trust with the families that you're working with, especially if these are historically oppressed and marginalized groups, how can you make them feel safe and that they can trust this, the setting? And I understand that it is hard when they're in detention, but as much as you can do to build the family, because the family plays such a protective role. And I always tell parents, you are like the protective seatbelt, right? If your kid, they're in adolescent years, there's a lot of brain development going on, there's a lot of risk taking. There's nothing that you can do to change that brain chemistry. They're like driving recklessly in a car, but what you can do is you can be like their seatbelt, right? Like you can keep them safe to some extent by, learning these skills and being involved. So I think those are my two, practice implications that I would recommend.
Great. And we had just one final question here for time's sake. Somebody said that the interactive activities that you were mentioning that were a part of your practice sound really helpful. Are they accessible to the public?
Yes. So right now we are about to submit the article for publication that describes how we do all of the activities. And as part of the publication, we're going to make the worksheets available. I talked about the interactive worksheets that I would give the parents so that they could practice the skills at home. So those will be made available. So I don't know if I can probably send them to you, Alicia, and you can share it with all the people that attended today.
Yeah, that would be amazing. Thank you. And so, Dr. Meza, I would like to thank you on the behalf of the YJI and everybody in attendance today for taking the time to share this incredibly important information with all of us. And before I get to our closing announcements, we want to pass it back to you for any final thoughts for us.
Well, first of all, thank you for inviting me to have this conversation. And I think this is just the beginning of a conversation. It's not something that I hope to end. I hope we continue this conversation. And I think the work of suicide prevention is not just for clinicians or mental health providers. Suicide prevention really requires all hands on deck. Everyone from any intercept, from any whether you're a researcher, a clinician, advocate, anything that you do, we all play such an important role in suicide prevention. And I think that's the only way that we're going to see the numbers go down is if we have an interdisciplinary, collaborative, systemic, social approach to address the social issue, because it is a social issue. It's an issue that is impacted by our social systems and our social ecology. So our interventions need to address that social ecology, not just at the individual level, give people skills on how to cope with distress, how to cope with anxiety and depression. Yes, those things are important, but how do we give people skills on how to resist racism, how to resist discrimination, and how do we integrate that into the work of suicide prevention? I feel like I'm preaching to the choir here because I feel like a lot of the people here, I'm like following the chat, they're like, yes, we do need to address social structural issues into the work of suicide prevention. And that is what I hope to do. And I hope everyone can go back and think about how they can address social issues into the work that they're doing, because it's so important.
Thank you again so much, Dr. Meza. So before closing today's webinar out, we have a final poll for our audience members. We would like to ask you how you felt about today's webinar. So we would like to launch this poll about how much you agree or disagree with the statements. The webinar was informative and the webinar was engaging. Please follow this or respond to this to the best of your ability. And while everybody's answering that question, I have a couple of announcements and items to put on everybody's radar. The next YGI Lunch and Learn webinar session will be held on November 8th at 12 p.m. Eastern with Dr. Maria Cherny-Buzio about reducing youth violence by focusing on mental health. The link to register will be in the chat shortly. And a save the date, December 19th, we will be welcoming Dr. Natasha Slesnik to talk about housing as prevention. Immediately following this webinar, we will be sending a survey to all of you via email. If you have time, please complete the survey as it allows you to provide further feedback and questions for us. The information will be used to improve future webinar sessions, and it should take no longer than 5 minutes. We'll also be putting the link to that in the chat now. Finally, if you have not already done so, please feel free to connect with us on Facebook, Instagram, Twitter, and LinkedIn. The links to those accounts can be found on our website. A reminder, the views expressed here are those of the presenter and do not necessarily reflect the views of the New York State Youth Justice Institute. And in closing, I want to thank you all again for taking part in this session of the YGI's Lunch and Learn series. We hope that you've gained something from this webinar and that you continue to think about what Dr. Meza has presented today and what she has charged us to continue thinking about. We look forward to seeing you at future YGI events and webinars.